Good afternoon, everyone. I am Dr. Abhishek, critical care SR. I'll be presenting an interesting case of use of high frequency oscillatory ventilation in inhalation and injury associated acute respiratory distress syndrome with bronchopleural fistula. Acute respiratory distress syndrome is a situation where we might need to provide high airway pressures and driving pressures in order to provide effective oxygenation and ventilation. And acute respiratory distress syndrome morphology, along with major air leak, poses a great challenging situation as majority of the ventilation modes are ineffective. So it mandates the need for rescue techniques and improvisation. So this is the case of bronchopleural fistula with massive air leak in a patient who had sustained inhalational injury and subsequently developed acute respiratory distress syndrome, and where we used HFOV as a rescue therapy. So our patient was a 30-year-old male who had sustained mixed second degree and third degree thermal burns amounting to 35% of total body surface area, and the major involvement was there in head, neck and upper torso along with bilateral upper limbs. At presentations to the ED of Burns Plastic Center, a patient was conscious, vitals were stable, but we noted there was singeing and darkening of facial hairs along with nostril hairs. So we suspected inhalational injury and we proceeded with the awake flexible bronchoscopic examination under under sedation and local anesthesia. So as we can see, the flexible bronchoscopy revealed hyperemia of the bronchial mucosa, of the tracheal mucosa, along with some shoot deposition along the trachea. It was deposited both in the mainstem bronchi along with the tracheal carina. So, but the patient was initially stable. So we provided the initial management in the form of humidified oxygen therapy, mucolytic therapy, inhaled bronchodilators along with nebulized heparin was provided as per protocol of management, and initial fluid resuscitation as per Burns fluid resuscitation formulas was given for the initial 48 hours, and subsequently fluid status was optimized. We also provided adequate nutritional support. However, in the following few days, the patient's respiratory distress, patient developed respiratory distress, and there were signs of increased work of breathing. So we had to employ high flow nasal cannula in order to take care of the increased work of breathing. As we can see, this is an X-ray obtained in the after a few days of ICU stay during the time of worsening, where we see there were bilateral chest infiltrates and blunting of bilateral costophrenic angle, suggestive of bilateral pleural effusion. The same findings of the chest X-ray was corroborated with a bedside ultrasound, which also showed bilateral B profile with bilateral pleural effusion. Cardiac function at this time was normal. In the following week, because of the bilateral pleural effusion with increased oxygen requirement, we had performed a bilateral thoracocentesis and drained around 800 ml of serous fluid from both the sides. However, due to the patient's respiratory status worsened and we had to employ non-invasive ventilation for a brief period. However, despite the use of NIV for a NIV trial, the patient worsened and there was evidence of severe ARDS like picture with oxygenation, surrogate used for oxygenation, PF ratio measuring to 90 millimeters of mercury. So because of worsening respiratory failure, we decided to intubate the patient and put on mechanical ventilation. Because the patient was having severe signs of severe hypoxia, so we also continued muscle paralysis during this initial period. Another promising option we had to offer for this patient was prone ventilation, but it was considered against prone ventilation because the patient had extensive raw areas, burn areas over the anterior chest, face and torso. And in the follow-up imaging, we had done a repeat ultrasound, which again showed recurrence of infiltrates and effusion bilaterally. This is the follow-up X-ray, which showed that there was an increased right-sided lower zone opacification, suggestive of new onset airspace opacification and infiltrates. And so we had put bilateral 20 French chest drain, which can be seen in the X-ray. And in order to remove the extravascular lung water, we had instituted diuretic therapy. The patients showed transient improvement. However, in the second week, patients started showing telltale signs of ventilator-associated pneumonia in the form of fever spikes, increased tracheal secretions, and again worsening oxygenation. In the endotracheal aspirate, there was a culture positive for multi-drug resistant Acinetobacter baumannii, and appropriate antibiotic therapy was reinstituted. In week 3, the patient by this time was in the ICU for more than 2 weeks and was emaciated. There was signs of ICU acquired weakness. Along with that, the patient was having post ARDS morphological changes in bilateral lungs with fibrotic changes. So due to all of these manifestations and signs, we anticipated difficult weaning, and we went ahead with a bedside percutaneous tracheostomy, which was performed on day 18 of admission. Now comes the day of when the major event happened. So during morning rounds, the patient had a violent cough, followed by patient suggested there was suggestive of the symptom suggestive of chest discomfort, and the patient had severe desaturation. And we noted there was continuous bubbling on the right sided ICD. Along with that, there was decrease in the breath sounds on the right sided ICD, right hemithorax, and there was hypotension and tachycardia. So we had started vasopressor infusion. So all of these signs and symptoms pointed towards the diagnosis of tension pneumothorax, and therefore we put a second large bore chest tube on the same side, on the right side, and we noted that there was massive air leak from both the right sided chest tube that was there. But however, the patient despite putting the chest tube, the patient was still desaturating, and the lowest saturation the patient could decrease to was 50% despite giving 100% oxygen. So at this point, we started thinking about other rescue therapies and other modalities which could save the patient, and time was also running out for us. So at this point, the initial strategy that we employed was institution of selective left lung ventilation. So we first removed the tracheostomy tube, and we had the flexible bronchoscopy at our bedside. So with its guidance, we had put a size 7 flexometallic tube into the left brainstem bronchus with an aim to mainly selectively ventilate the left lung and isolate the right lung, and decrease the air leak. However, as I've already said, the patient was in post ARDS morphology, had post ARDS changes in the lungs, and the left lung was also diseased. So we could not maintain adequate oxygenation despite left-sided one lung ventilation. So we had some partial success. Saturation had improved transiently to 70%, but we could not. That was not sustained for a long time. And ABG obviously showed signs of persistent hypoxia and also hypoventilation. PCO2 had also gone up to 95 millimeters of mercury. This is at this time we had thought of another rescue therapy, and kind of as a last resort, so we opted for a high frequency oscillatory ventilation, which was in the working condition luckily at that time. So we had shifted the machine to the patient's bedside, and the patient already had a flexometallic tube in its trachea inserted. So we had employed high frequency oscillatory ventilation with the following setting: bias flow of 40 liters per minute, delta P of 80 centimeters of water, airway pressures of 28 centimeters of water, 100% oxygen, inspiratory time of 33%. High frequency oscillatory ventilation is a mode of ventilation where a special device ventilator is used, and there is a piston which strikes against a diaphragm, creating very small tidal volume of 1 to 2 ml per kg with a high respiratory rate of minimum 150 to 180. We can go up till 900 per minute, and the main driving forces are quite different from a conventional mode of ventilation. It will be discussed in the later slides. During this time, we had to continue sedation and muscle paralysis. So this is the picture demonstrating the patient with the flexometallic tube in C2 and the high frequency oscillatory ventilator at rest and functioning. While on high frequency oscillatory ventilation, and the patient started showing signs of resolution of the air leak. and we could maintain acceptable blood gases, like oxygenation and ventilation was maintained. And gradually we started titrating the FiO2 and the mean pressures gradually, and also the frequency was also adjusted in order to maintain a partial pressure of carbon dioxide around 45 to 50 range. We noted there was a air leak had reduced significantly, and by day 2 of HFOV therapy, the air leak was almost gone. It was imperceptible. And after 72 hours, after judging all the clinical parameters, blood gases, and the patient's clinical scenario, along with imaging and the ventilator waveforms, when the mean pressures we could reduce to below 12 centimeters, along with an acceptable FiO2 of less than 0.4, and patient had sustained normoxia, so we had switched to conventional ventilation. So this is the picture showing this was obtained just after initiation of high frequency oscillatory ventilation. As we can see, this is the flexometallic tube which is put, and this is attached to the HFOV circuit. There are two ICDs, one posterior, one anterior on the right side, and one ICD on the left side. And this is the pneumothorax on the right side, which had caused all the problem initially. And after 6 hours of HFOB initiation, we could see that there was clear signs of expanded lung on the right side with the ICD in situ. So after this, we had again reinstituted conventional ventilation, and the flexometallic tube was still in situ. We had connected to a normal ventilator by this time, and the patient started showing gradual signs of improvement, and so we could switch over to weaning modes in the form of pressure support ventilation, and subsequently there was the patient gradually improved. For a diagnostic workup, we had done a diagnostic flexible bronchoscopy after we had put him on pressure support, and to detect if there was any gross leakage sites, or any tear of the of the trachea or the mainstem bronchi. So there was no obvious signs of air leak. We had performed an HRCT chest. So this is an HRCT chest which was obtained after stabilization of the patient and liberation from HFOV. So this is showing right-sided middle and lower zone dense consolidation, which was because of the post-pneumonic ventilator-associated pneumonia and pneumonic sequelae. And we can see that there is a giveaway, or there is a fistulous tract from the right middle bronchus. This, and as we go down, this one is almost going and getting connected to the pleural cavity. So this was the source. We had decided probably this was the source of the major air leak. And on the right hand side, we can see that after all these acute events had subsided, the patient had almost a near normal lung with minimal fibrotic changes. And the ICDs by this time has also removed. So we started liberating the patient from the ICU. So the patient was gradually weaned to TPs, and then subsequently all these tubes, chest tubes, were removed, and supportive care in the form of chest physiotherapy and deep breathing exercises were continued after the patient was decannulated. And ultimately the patient was shifted to ward on day 36 of ICU, after day 36 of ICU. And thereon, the patient underwent multiple skin grafting by the plastic surgery team, which were again performed under general anesthesia, and all of the times it was performed uneventfully. Finally, the patient was discharged, and currently the patient is at home performing all the daily activities independently without any sequelae of the events that you had. Now, for discussion session, I would like to call upon Dr. Priyankar. Thank you.
Good afternoon. So this case, it shows the successful use of one of the archaic modes of ventilation, HFOV, which is now almost in adult practice considered archaic. So we have successfully used HFOV both as rescue therapy as well as a bridge to recovery in a patient with massive air leak. The exact cause of BPF in our patient is difficult to pinpoint. It could have been a result of direct thermal injury because of the inhalational injury that the patient had. Repeated suctioning of the inflamed airways could have caused injury, causing a BPF. Patient had VAP because of Acinetobacter baumannii, which is a known cause of necrotizing pneumonia. This itself can cause air leak. During ARDS ventilation, patient required high airway pressures, which could have complicated the matter. And finally, it could have been iatrogenic during thoracocentesis to drain out the pleural effusion, or during chest tube insertion. However, during subsequent imaging, we found that the BPF, the fistula was originating very close to the hilum. So it is very unlikely to be iatrogenic, where it should have been more peripherally located. The reported mortality from BPF, it is a wide range reported from 18 to 71%. And this wide range is because of variations regarding the underlying cause of BPF and the severity of the BPF. So the basic principles of management of BPF, they include infection control, nutritional support, and closure of the fistula. The closure usually requires endobronchial approach or surgical techniques for closure, and sometimes closure can happen spontaneously, as it happened in our case. BPF under positive pressure ventilation, it is a more complex problem. The air leak makes ventilation ineffective because all the ventilation that we are giving escapes to the BPF. On the other hand, the positive pressure itself impedes the healing of the broncho-pleural fistula. So ultimately, it becomes like a double-edged sword. So conventional ventilation in BPF, the goals of ventilation, it is to minimize air leak and promote healing. So this is done by keeping the peak pressures below the critical opening pressure of the fistula. Usually is agreed upon that around 30 centimeter water may be the critical opening pressure. So peak pressure should be kept below 30 centimeter of water. And at the same time, this gentle ventilation, it should be adequate in achieving adequate inflation of the residual pulmonary segments. Conventional ventilatory strategy, this includes low PEEP, low short inspiratory time, low tidal volumes, and accepting a degree of hypercapnia, because we don't want to overventilate the patient. And we should use spontaneous modes whenever feasible. However, if the patient has a very large air leak, or if the patient has poor lung compliance, so if the other pulmonary segments, they are very stiff, then this gentle mode of ventilation may not be adequate, and this will require novel therapies or rescue strategies. So what are the rescue strategies for BPF in which conventional ventilation fails? So we can go for lung isolation strategies. This can be partial lung isolation or can be complete lung isolation. Partial lung isolation means use of bronchial blockers. Selective bronchial blockade can actually help identify which lobe has the BPF, and we can keep the bronchial blocker in that particular lobar bronchus and ventilate the rest of the lungs. On the other hand, we can go for complete lung isolation if we cannot identify exactly which lobe the fistula is in. However, these lung isolation techniques, the success depends on the condition of the remaining lung. If the remaining lung is not great, then if you isolate a portion of the lung, the rest of the lung may not be adequate in maintaining gas exchange. We can go for differential lung ventilation using a double lumen tube and connect the two lumens to two different ventilators at different settings. However, this is difficult to maintain for prolonged periods, and it is difficult technically. We can go for bronchoscopic, thoracoscopic, or open surgical closure of the fistula. However, these procedures require some degree of hemodynamic and gas exchange stability, which was not there in our patient. Our patient was desaturating very fast, and these procedures may not have been possible. And finally, veno-venous ECMO, which is considered the gold standard for managing BPF today. However, it has its own problems. This includes limitations of cost and logistics. And finally, cannula placement. Our patient had extensive burns involving the face, neck, and upper torso. So placement of the return cannula would have been very difficult. We would have had to go through the burnt skin, and it would have predisposed to life-threatening bloodstream infections. So why is HFOV effective in case of a BPF? So conventional ventilation, it depends on bulk flow. Bulk flow means it is the in and out movement of large volumes of gas to achieve ventilation. However, HFOV, instead of depending on bulk flow, it depends on augmented diffusion. So the entire column of gas, it is agitated so rapidly that this causes diffusional mixture of the gases and diffusional exchange. So it does not depend on bulk flow, but rather depends on augmented diffusion. This is why adequate gas exchange can be achieved at much lower peak pressures compared to conventional ventilation. And this aids the spontaneous healing of air leaks and helps in adequate gas exchange. So there have been a handful of case reports in which HFOV has been used for BPA for air leaks. One of them is from our very own trauma center where HFOV was used to treat a patient with chest injury and massive air leak. HFOV in today's adult practice is kind of almost archaic or not used very frequently. Earlier, it was used in patients with adults with ARDS. However, two large trials in 2013, the Oscar trial and Oscillate trial, they showed that compared to normal low tidal volume ventilation, HFOV does not offer any benefit, or rather, it could increase mortality. And so, mostly in adult practice, HFOV has been abandoned. However, we have to keep in mind that these trials, patients with pneumothorax or broncho-pleural fistula, these patients had been excluded in these trials. So we don't know whether HFOV can actually be of much benefit in patients with ARDS and major air leaks. And when conventional low tidal volume ventilation fails in cases of ARDS with BPF, HFOV may be successful. So finally, our take-home message from this case discussion. So HFOV should be considered as a management strategy in cases of large air leaks due to broncho-pleural fistula. Unfortunately, HFOV is a dying skill, and most of these machines have fallen into disrepair or usually condemned and not used anymore. However, the good thing about HFOV is that it is less of the HFOV ventilator. It is actually a machine in true sense. It is less of a computer. It does not have any microchips. It does not have much complicated electronics. It is a very basic machine, very easy to maintain, very easy to repair, and very easy to operate. So if we have the machine in our place, we should keep it ready. We should keep it in working condition for the rare situation where this may prove to be the difference between life and death. Thank you. Yeah. If anyone has any questions regarding our case or HFOV, then
Thank you, Dr. Pinga, for excellent presentation. I have one query. You did one bronchoscopy in initial stages. Is that protocol of for doing bronchoscopy in every patient with one?
sir, in case we are suspecting inhalational injury, so the suspicion can be from the mechanism of injury. If it's like a close spaced injury, or in this case, it was by when he poured kerosene and set himself on fire. So in these mechanisms,
Patient is maintaining saturation. That time patient is saturation.
Hmm.
Don't you think that doing the one intervention at that time
right, sir.
can cause further trauma?
Sir,
Can that be the cause of that bronchopleural?
I don't think that was the cause, because we do a very quick and very gentle bronchoscopy look, and it is required to prognosticate whether the patient will actually develop into post inhalation injury complications like ARDS and pneumonia.
Is that a protocol?
It is a protocol, and it is done in major most burn centers.
Thank you.
Ma'am, we use a number 7 flexometallic tube.
Left bronchus.
For the left bronchus. We initially put it into the left mainstem bronchus. Then that was during one lung ventilation, and that just bought us some time in which a HFOV machine could be arranged. It was arranged from trauma center, brought to Burns and connected. When we were about to connect the machine, we removed the tube from the bronchus and brought it back to the trachea, and then we started with the HFOV.
So it was done with tracheal
Yes,
ventilation.
HFOV with tracheal.
Do we have tubes for endobronchial intubation in India? Because 5 years back it was not there in India, but in Australia and other places they are available. Do we have?
I'm not really sure regarding the answer to this question, but in our ICU, we did not have any other specialized tube for endobronchial intubation.
India.
Regarding thermal injury, is it not a protocol to directly intubate the patient rather than going for NIV?
No,
I'm not aware
NIV, ma'am, the NIV requirement, it was not per se purely because of thermal injury. This patient had gone into ARDS, that could have been secondary to thermal injury. Patient also had massive pleural effusions with underlying lung collapse. So NIV was just tried in a way to help recruit the lung. But in case of thermal injury, I agree. If there are overt symptoms of airway involvement, we should not go for NIV. We should go for early intubation, because the airway inflammation goes up very rapidly. Edema goes up very rapidly.
Thank you.
Yeah, sir, one more thing. Once you are doing the tracheal ventilation, then why flexometallic tube?
Okay, ma'am, we had this patient was tracheostomies initially. Now HFOV, the entire principle of HFOV depends on laminar air movement. So if we have an acute kink, so if you have an angled connector, then HFOV will not work. So we need a smooth transition or a smooth curve from the trachea to the external machine. So that is why we have continued with the
And how the
That's what-
ventilation is set? Any set parameters?
So in HFOV, mainly we have to set the airway pressure, the mean airway pressure, and oxygenation depends on mean airway pressure. So if we cannot achieve adequate oxygenation, we can do two things. We can increase the FiO2 up to 100%, and if that is not achieved, we can go up on the mean airway pressure. The second is ventilation or removal of carbon dioxide. So this depends on two other parameters. One is the delta P or amplitude. So we cannot go too much. So we try to set an amplitude where we can see visible chest and abdomen vibrations extending up to the mid thighs. And second, we go for frequency. Actually, HFOV, the benefit will only be available at very high frequencies. However, if we cannot achieve adequate gas exchange, that means adequate removal of carbon dioxide, we can actually reduce the frequency. This is unlike normal ventilation, in which to remove carbon dioxide, you increase frequency. In HFOV, you actually reduce the frequency so that individual tidal volumes increase and we can achieve adequate gas exchange. That is how we maintain the gas exchange.
Yeah. So, Priyankar, really a good management, and must thank you and congratulate you managing the complex case really beautifully. So, my question is, how do you decide when to convert to a conventional ventilation from HFOV? What are the objective parameters did you look at?
Sir, in this case, we looked at maybe a couple of things. We looked at whether the leak had gone down to very minimal levels and it had actually completely stopped. Second, whether the mean airway pressure. So we switched back from HFOV to conventional ventilation when the mean airway pressure was less than 12. Requirement was less than 12. So in conventional ventilation, the mean airway pressures that are usually achieved in during the weaning phase are around 12 to 15, not more than that. So once we had on HFOV, we had come down by the mean airway pressures to less than 12. We had switched, and finally FiO2 requirement was less than 0.4. So these are the three things we looked for before switching from HFOV to conventional ventilation.
How many days the patient was on HFOV?
The patient was on HFOV for about 72 hours. 72 hours. The leak actually came down very rapidly. The leak had stopped by maybe 12 hours, but then the oxygenation improvement took a little bit of time. Thank you very much. I think we'll go for the second.
Good afternoon, everyone. So let's move on to the second leg of the CCR today. I think the anesthetists have left, the surgeons have now come into the picture and anesthesia have gone for a break. So today we are going to present two interesting cases of cellular lesions where patients presented with clinical and radiologically mimicking a true garden variety pituitary lesion. However, our pathologists beg to differ and they had made some interesting diagnosis. So now I'd like to invite Dr. Ganesh to start with the clinical presentation and then the other specialists can pitch in. Thank you, sir.